This week on the BackTable podcast.
I mean, these cases aren't for the faint of heart. Like you have to, I think the biggest point is, I always learn that you could teach any monkey to push a needle or to do a case or whatever. What I think may not come across in these discussions and like, oh yeah, this is what we did and we were successful and we were out, is the hours of back and forth of the planning of the what if this happens, what if that happens, what if we do this, like there's so much discussion and so much planning and so much thought that goes into these cases before you take on something like that, because the fact of the matter is that we're doing stuff that is not support. I mean, people get denied for procedures that are quote unquote experimental, but we're doing them day in and day out and we know they work. This is truly experimental.
Today, we're going to be discussing mesocaval shunts. We have done a lot of episodes on portal hypertension, but for those that want to go back and re-listen to some of the things in the catalog, we had Riyadh on the show for episode 223, portal vein recan. We did TIPS University with, advanced TIPS techniques with Emmett Linsky. That's episode around 126. And recently we had Ben May on from Cornell discussing acute PVT. That was episode 541. We have Dr. Chengazi and Omar Chohan. Both graciously came on the show with me to discuss declots. That was episode 420. 420 for all you cannabis heads out there. And Harris, we also had you on for a tips episode 455. So I think I did a good job recapping everything. Guys, welcome back to the show.
Yeah, thanks for having us again.
It's always a pleasure.
We'll start out guest introductions. So Omar, do you want to tell us a little bit about the practice and then we'll dive into the portal hypertension work you guys do?
Yeah, my name's Omar Chohan. I'm an interventional radiologist in Buffalo, New York at Great Lakes Medical Imaging. Been here for about 5 years. We're a pretty good group. We do a little bit of everything. We do venous work, complex, hepatobiliary work, arterial work as well, and the bread and butter.
And then private practice, right? How many IR docs?
We have 6.
6 total.
Moving on to 7 pretty soon.
Nice. Horace?
Yeah, not enough, there's always more to cover. But yeah, Horace Chengazi, I joined the practice, was it 2 years after Omar did. And obviously private practice, a high complexity, highly clinical, group that is a lot of fun. Part of what we're talking about today is going to be, our series of what we call Chengazi cases. We do a lot of cases dual scrub and, we got a little hashtag going on Twitter and everything for those too. So like complex venous recans and these mesocaval shunts and stuff, we'll move around both of our schedules and get the Chengazi day going.
Those are the best days.
All right. Well, that's great. So let's just jump into it. Introduction, mesocaval shunts, what are they? And what are the common pathways that we're going to be talking about today?
Yeah, I mean, usually whenever I'm approaching a patient, when this might be an option for them, I tell them this is a pre-TIPS procedure. So before TIPS was ever considered an option, this was a surgical procedure where the patient was opened and an anastomosis between the SMV and the IVC was created. But it was difficult because many of these patients were cirrhotics with ascites, high bleeding risk, poor wound healing with ascites, and it never really took off with popularity until TIPS came around and sort of took away the mesocaval shunt. But we sort of repurposed the mesocaval shunt when TIPS is no longer an option, so we've kind of flipped it. And these patients, they don't have an accessible portal vein, or they may have an atretic portal vein, and the SMV or its tributaries might be enlarged enough as varicose veins or just with the portal hypertension, and they serve as good targets to reconnect towards the IVC. So when we're looking at images, we're just trying to find where is the most direct route to connect the SMV or its tributaries to the IVC.
So all these patients that we're talking about, are these all patients that you guys have a failed TIPS, or you think a TIPS isn't feasible?
The TIPS was never really an option for any of these patients.
For what reasons?
If the portal vein wasn't open, or if the disease process was pre-sinusoidal.
Yeah, so some of these patients had severe cavernous transformation with multiple small sort of branches, we always kind of assess for potential transhepatic or transsplenic recanalization. But then you kind of have to look at, okay, where's our recan going to be and where are we going to drop, our stents, what's our access going to be? If they're chronically occluded, calcified, occlusions of the portal veins, also that's a consideration. And then another factor too is like if a good window presents itself, if you think like, hey, we could spend hours and hours and hours trying to recanalate gun site, transhepatic, transsplenic, etc., which carries with its own risks in the appropriate setting. And you'll see some examples here. It might be simpler and more straightforward to go for a mesocaval shunt because the window presents itself.
I like that. All right, so let's talk about like the patients that you guys have worked on. Like, what was the referral pattern? How did they end up in your clinic, or how did they like end up in front of you? And then I was kind of interested to like dig down into the workup or the pre-procedure planning for these cases.
Referral pattern for these patients, the first patient that we interacted with was actually a patient that Omar and I both, we basically saw her every week on a rotating basis for paracentesis. And she was relatively young. She was otherwise, pretty healthy. But I think she was coming in twice a week for 5-liter paracentesis for almost 2 years. And it got to the point where we just were wondering, like, is there anything we can do for this person? And we ended up, Omar and I live near each other, and we talk about cases all the time. And we'll sometimes just like, conference call and go through things. And we start looking at her imaging and, well, what if we did this? What if we did that? Like, is PV recan an option here? Like, is there something we can do? And that's where we kind of started looking at the anatomy. And this patient specifically had a very dilated gastroepiploic vein kind of coming along the greater curvature of the stomach and then feeding into the superior mesenteric vein. And I think it was Omar's idea initially on that case of being like, hey, if we could see that with ultrasound or CT and access that, then theoretically we could basically trace that vein up to the SMV. And once we're there, you do this like pop a balloon and puncture, a dips technique kind of, and connect the dots and drop a stent. So that was the first case that we sort of interacted with. And, after having that conversation of, hey, something might be possible, I think Omar broached it with the patient. And Omar, you can speak more to that if you like.
Yeah, she had like autoimmune hepatitis and really no therapeutic option. And she was subjected to, again, the biweekly paracentesis. So it wasn't too hard to ask them, hey, you're very young. Your options are very limited. Your quality of life is close to nothing. We could try this. It's not going to, aside from major complications, this isn't really going to make things worse for you. And it has an option to make your life a little bit better, even if we can reduce to once a week or maybe twice a month. So she was agreeable to it. It was, she was Bengali speaking, so the translator was always kind of a little bit of a challenge to kind of really get the point across. But they were pretty open to the idea of trying to do something to improve her quality of life. And by the time we were done, she was comfortable enough to move to a different town.
As far as just the clinical workup beforehand, obviously, so you have someone autoimmune hepatitis, 2 pairs a week, 5 liters are coming off, 10 liters total for the week. But do you need to know MELD score? We're just going to assume for this conversation, coagulation parameters, those kind of things. You would expect that you want to have them like within range.
Yeah, the workup is no different than doing the TIPS workup, right? So we do want to make sure that the MELD score is reasonably low for these patients. Our so far the experience that we've had, the younger the patient, the lower the MELD score, the better success.
Yeah, the other thing is I'm always, MELD score is a big one, but the other, like we usually cut off of around 20 for our MELD for TIPS. I'm sure that's relatively standard practice. But depending on if it's, liver-driven disease or renal-driven disease, in patients with chronic diuretics and hepatorenal syndrome and whatever else, I'll tolerate a higher MELD score if it's mostly creatinine-driven. But the bigger thing is, I think, the clinical factor of like, what does the patient look like? Do they look like they can tolerate this type of procedure? Do they look like they could potentially tolerate a complication and would be able to bail them out? Because that's something we'll talk about in this case also as our first sort of run through. And the hepatic encephalopathy and heart failure components, I think, are really important because, as we'll talk about in some later cases, the significantly increased return directly back to the IVC and to the heart can cause some pretty significant changes for the patients also, including like exacerbating venous insufficiency and that sort of thing also. So you really have to have a very good understanding of a baseline for the patient and an assessment of their functional status and frailty, et cetera, before making a decision like this.
But like, there's a lot of like parallels between the mesocaval shunt workup and a TIPS workup, right? I mean, basically. Okay.
Yeah, it's pretty much.
All right.
You're connecting different dots, but it achieves the same end.
Day of procedure, anesthesia, GA. Okay.
Oh yeah,
All right.
Definitely.
Yeah.
Antibiotics?
Definitely. Not typically.
Not typically, but I mean, you can give it grant and stuff. I'm not very particular with it.
There was one case where we did give antibiotics because the bowel was presenting a very difficult window. And just in case we perforated or punctured something, I mean, if you're using a smaller needle, it's not a huge deal, but it was kind of prophylactically given. But I'm not in the routine business of giving antibiotics for pretty much any intervention. I think we overutilize antibiotics, and I know that's against some guidelines, but haven't had an issue. I think it depends on clinical evaluation and assessment for the patients.
I like that, Horace. Bold statement.
Another thing that we should talk about, Chris, is equipment, right? Because that's one of the big things here is that we are very, very fortunate to have the accessibility of a what's called a 4D CT scanner. So the neurosurgery department, Gates Vascular Institute has they did a lot of early stroke interventions. They've got a very high yield neurosurgery, endovascular neurosurgery department, and they basically had it's like a $4 or $5 million 4D CT scanner installed. And what that basically is a fluoro table with a CT scanner on rails that can come in over the table, and you can do diagnostic CT scans and fluoro CT runs while you have endovascular access or injecting contrast, doing runs, whatever else. So with those two things, it kind of gave us the freedom to be a lot more creative because you don't necessarily need to be able to see where you're accessing with CT or fluoro because we can access under with ultrasound or fluoro. We can access under CT and then convert to fluoro to basically complete the case right on the table without having to move the patient, without having to do anything. So we can start the case like a normal CT case would be with a grid, mark our sites, numb, whatever, puncture, and then from there, verify wire position, et cetera, after we've switched over to fluoro and we're ballooning and we're doing all that thing to make sure we're not going through bowel, make sure we're where we want to be, make sure we're through and through with CT fluoroscopic shots. And so that hybrid room accessibility has been huge. Now, one of the cases that we ended up not even really needing the CT component. So I think this is still a good conversation for people to have, to be creative about the way that you approach these cases, because by thinking about these things, you might find new ways of getting stuff done. But we did have that very, very large privilege of being able to use this room to do these cases.
And so when you're using the CT component, the CT component is basically for your access to make sure you're not traversing something you shouldn't. And then once you have venous access, are you ditching it and then going to fluoro?
Well, it's more than just you confirming we're not going through something. Like for two of the three cases that one of the cases definitely, it was for the access entirely. I mean, we basically took an 18 gauge Hawkins needle, we punctured through the skin to the peritoneum, put in the blunt stylet, basically went over the stomach, under the small bowel, through the mesentery, across the river and through the woods.
I saw that one on Twitter. The access, it was pretty cool.
Yeah, so we got to the SMV, punctured into the SMV, make sure that we had blood return. Then we made sure our angle was good and punctured through and through the SMV into the IVC. So that was all done with CT. And then once we had the wire into the IVC and we flossed out the neck, then we kind of converted over to working with the fluoro component so that we could watch our catheters in real time and make sure our devices were landing where they wanted to go, et cetera.
Man, I'm just letting that sink in. I mean, so like transabdominal access all the way. So you spear the SMV and then just keep pushing through. Like, you have SMV access, you aspirated blood and keep pushing through. And then you basically hit the IVC and then that's your access.
Yeah. Once you're different to your body, you're there.
And that was 18 gauge. So
bit.
You just went to an 035 wire immediately and then, oh, that's pretty slick.
Mm-hmm.
Okay. That's pretty neat. Okay. All right. I have all these questions about the procedure. I just think that can we get into the cases and then I can just ask all the questions as you guys are kind of breaking down the cases? Okay, sure. Let's do case one.
So case one is the first patient we were talking about, the patient who's getting biweekly paracentesis, large volume.
This is your first one, right?
This is our very first one. This is the one where we probably talked about it for, 10 hours offline beforehand and drew pictures. And that's another thing that we should mention, going into these cases, it's not like the 4D CT scanner is in a different area than our usual fluoro room. So we had to plan every aspect of it. How was anesthesia going to set up? Which way is the tubing going to run? Where are you going to put the vent tubing? Where is the nurse going to stand? Where's our screen going to be? And then on top of that, 2 of every possible device that we would need, because we didn't want to be in a situation where we've got access, we need something, and somebody's got to run up 4 flights of stairs to go grab something or wait for an elevator or whatever else. So, shopping list, we're going to need probably this length stent, this size sheath, angled glide cath. We want multiple, 035 GWAs. We want multiple 018 V18s if we need to go buddy wire access, etc. And just have that whole shopping list and a cart with everything available right there, so that we can kind of move from step to step pretty quickly and minimize the time that we're fumbling. Yeah. So from there, I guess the first case, it might be best if we just include the slideshow images. Omar, if you could provide at least the axial CT images, we could maybe just show, but the basics for this case were that this patient had massive ascites. You'll see what the portal venogram looks like here, but there was essentially a vein that was running, down from the SMV up and over across the anterior aspect of the abdomen. And, basically right at midline, maybe a couple centimeters deep to the skin, there was about a 8-9 millimeter gastroepiploic vein.
Pretty juicy.
And the thought process there was pretty juicy, exactly. So the idea was we should be able to see this with ultrasound. We're going to need to drain the ascites, just in case we have any bleeding complications or anything, but we should be able to find this vein. And if we can find this vein, get a catheter in, then, we have a portal venogram right then and there. So on the screen here, this is our first initial access. So you can see where, you can see the colonic gas. You can see this is a microcatheter from a 018, micropuncture sheath in with a contrast syringe attached, and we've accessed that vein and basically are injecting. Let me see, what is this scrolling? Okay, so this is our initial injection here from that. So this is a vein running over, coming across, and this is not the main portal vein. This is all cavernous transformation of the intrahepatic branches. You can see, obviously there's portal hypertension here because we've got reflux going down the IMV there, and then a lot of gastric varices, etc. But this is the initial picture. And on this image, you can also see that we have an ice catheter in over here to help watch, a TIPS needle for access. So that was just a backup thing that we did. So starting from the very beginning, we got jugular access, we got groin access, we placed an ice catheter, we placed a safety wire in the IVC, and then we basically punctured this gastroepiploic vein under ultrasound and took this initial picture. And so you can see kind of near midline, we've got all these structures overlying one another. And the thought process was to basically get a catheter and a wire up into the largest, juiciest portion of the SMV overlying the IVC, put a balloon up in the SMV or one of these varices, and then puncture like a dips directly from the IVC into that balloon. And by doing so, hopefully be able to just pull the balloon back with the wire fed inside it and have floss access basically from the neck out the abdomen through the future mesocaval shunt.
And from the cross-sectional imaging pre-procedure, did you have an idea of what branch or which part of the SMV that you wanted to access? I mean, because I guess I just see this and I'm a little bit disoriented and choosing. I mean, I'm not saying there's no target, but I'm seeing maybe a couple places that might serve as a good place to gun sight and go to the IVC.
We did essentially look at the imaging in all 3 planes, and the thing that we had to watch out for here is that she had a pretty small window that was essentially between the liver margin and the pancreas. Okay, so there's the uncinate process of the pancreas was sort of hooking around, and we basically had to access the SMV in a window that basically didn't go through the pancreas. And so we orient that by using localizer modes on our axial CTs. We kind of know these veins are large enough to identify reliably under CT, and we knew that once we got to the level of this tortuosity, we were above the level of the pancreas. We were still not quite at the hepatic capsule to be puncturing through there, and we knew that sort of this ballpark right here, which is conveniently also the one that's right in front of the IVC, was going to be the best spot to go to.
And this is a straight AP shot, right?
This is a straight AP shot. Yep.
Okay. Do you do an IVC gram or a venogram here?
Here's another injection just under fluoro to help us localize. Okay. I think this is working a little bit better now, making sure we're in the right place. Just have to bear for our patients here as the computer wants to struggle with us. This was an oblique shot that we obtained just to kind of see and correlate our ice images and make sure that we were going to have a good visualization of our actual puncture site. So we just, this is our first time doing a case. We ended up just obliquing and taking multiple pictures so we could, basically think it out and talk to one another as we're doing the case.
And so you haven't gotten like that much further. Okay, here you go. So now you got wire. Okay.
Yep. So those were all the initial pictures. So now we've got a wire in and we're injecting again just to navigate. I kind of want to get to the next picture. Okay. So now basically we've driven our wire up to our target branch and we've put a balloon up essentially inside that SMV collateral. And here we were basically just trying to get our tips needle set down. This is going very slowly. I think initially Omar wanted to check and see if we had an intrahepatic route to basically go from a hepatic vein to the balloon. But the hepatic vein anatomy, as you can see here, was pretty angulated and pretty high up. It was a pretty long throw. So we did a venogram. We watched under ice, but we couldn't get a good ice image. I really like getting a picture where you have the hepatic vein and the portal vein on the same image simultaneously. And since we couldn't get that here, then we ended up, Omar's idea again here was like, why don't we do this like a DIPS? Because we can see where we are in the IVC really well. And so this is the kind of money shot image where we've essentially, got our balloon up, our wires up into the SMV collaterals. This is an Argon Scorpion X tip set. So it's got, I like that kit because it's got a stiffened angled cannula and then a second, needle that you can rotate in multiple directions. And we essentially pushed up against the wall of the IVC. One of us is at the neck, one of us is at the groin, and then push the needle forward and essentially watch. This is one missed pass. So let me go back and pause there a little bit, right? So, did a pass and we went past the balloon, use a lateral to basically help and triangulate where you are.
Are you also like at this point using ice to like, do you have that kind of visualization or ice is not really catching the SMV part of it?
The ice, we thought we were going to be able to use ice here, but once we started to go beyond the IVC, we weren't really seeing a whole lot very much. So we kind of switched over to a fluoro-guided approach.
All right, so you're making passes with the Scorpion, the tip set from IVC to the balloon, which is positioned up in the SMV or an SMV collateral, and you're just making passes until you strike.
Basically, I think we only made like 2 or 3 passes. So after the first pass, we thought we were close, went to the lateral, noticed that we had gone a little bit superior and anterior. And so we repositioned our initial puncture site based off of that and went a little bit lower down. You can see we're targeting a bit lower on the balloon here also to sort of correlate that because the balloon position hadn't moved. And this was actually the puncture that pops the balloon. So this is a sort of money shot right here where, we know that we've punctured from the IVC into the SMV collateral. Now that we know that we're in a balloon, this is a part of the case where you got to kind of move very quick. The balloon's deflating, but you want to get wire into it because it's a fun technique to do it right. But, you get wire into it as much as possible. And then I kind of pull the balloon back. So you basically use it because it would have been a pain to try and snare and get all that access also here. So essentially from this point, we pull the balloon back and out through the skin and we've got floss access.
And with that needle, like, are you going is it like a V18 wire or is it like an 035 that goes into the balloon?
We used an 035 exchange length glide initially. 1, it was soft enough to basically deform inside the balloon. 2, we guaranteed that it had enough length to have it on both ends. And once you have it on both ends, you can apply enough tension that you can generally pass devices pretty easily despite the stiffness of the wire. The V18s, they're great, for a lot of stiffness and rigidity, but I think you need to have reliable access at that point because that stiffness can also kick you out. And when you're working in extra anatomic anatomy, it can be really tough to make sure that you're in the right place. So.
All right. So at this point, you have flossed access from IJ to basically abdomen. And then the rest of the work that you're doing, like all your working balloons and devices, you're going through the IJ.
Yep. So this is the next image that we had. Basically, after the floss access, we took a 4 French angled glide cath, drove that down. It curled back on itself, but we injected to make sure that we were in the SMV. So we've got jugular access into the SMV branches, and this is a point at which we know that hopefully we should be able to get nice, reliable wire access and basically work from the neck all the way down. You can see we've swapped out that micropuncture sheath for a 5 French access sheath over here just to maintain something inside the vein.
All right. I see it. Follow. All right. So your catheter from the IJ through IVC into the SMV collateral. And so, you have access here. All right. So you get your wire in and then what's the next step? Like you have to plasty, then lay down the stent.
Yeah, so the next step is you got to get your 10 French sheath into the SMV, just like you would for a tip. You need your sheath into the portal vein. All of these cases that we've done, it's an interesting point to talk about. The goal was actually to use the Viator stent as the one that we're most comfortable with, because we didn't want to use, we wanted a covered portion of the stent because obviously you're coursing through non-venous anatomy, and we want to make sure that we're not bleeding out into the peritoneum or retroperitoneum. But that uncovered portion of the stent was also very important because we're dealing with all these complex collateral networks. We're seeing 2D images. We wanted to make sure that whatever we left inside the mesenteric veins wasn't going to cover any branches that might be at risk for causing bowel ischemia or suboptimal drainage, etc.
Just looking at this is, I mean, this is a pretty tight angle. I mean, but I mean, obviously you do it, so keep going. Let's see it.
Yeah, so I mean, it seems like a tight angle, but you know, it's kind of superimposed on itself. So now we've basically used a wire. So you know this curvature here that you're seeing at the bottom of the image, that's the course of the gastroepiploic vein. So we've taken, I think it was either the soft glide wire or an advantage wire, and navigated with that 4 French glide calf past our sheath access into that gastroepiploic vein, and basically straightened everything out so we have a nice tight sheath. And from here, once we've got a nice sort of straightened out angle and a good access site, the goal is essentially to balloon the tract and then swallow the balloon with the sheath into the mesenteric vein, so that we can then size our stent and then, you know, deploy our tips. So here we're confirming our position. We've got our access all the way past our percutaneous access site. You know, we were able to place a nice stiff wire. We're doing an IVC cavogram, you know, basically to assess our site. And I think we do a dual injection here also to basically just show us how the anatomy is overlapping and where we're going to be going. Again, was this really necessary? Maybe not. When it's the first time you're doing a case, we're essentially just looking at every image that we can possible to make sure that we're, you know, trying to catch any hiccups that we might run into. Just another angle here of the IVC venogram with that SMV shot. And so now this is an oblique angle as well. This angle was important because, you know, once you're looking at those frontal 2D images, you don't really have a good sense of what length you're going to need. You don't know exactly where your IVC puncture is to leave the IVC, nor do you have an exact sense of where the SMV puncture is. So we were using this to essentially help us measure and determine where the anatomy was going. We're ready at this point with a 10 French sheath. We've also got a long balloon. You can see the 2 markers here in position. And we did an oblique venogram from both sides basically to see if we could see the IVC and the puncture site. So you can see that SMV puncture site here. You can see about where we're leaving the IVC over here. And the goal is to make sure that our balloon is long enough that we're going to be able to swallow the balloon and get that 10 French sheath into the SMV. We started with an 8mm balloon. And that's just a standard practice generally when I'm doing my tips. I know that we're going to post dilate to 8mm as well. So we'll use that balloon so we can reuse the same one to post dilate the tips. Fortunately, didn't have any trouble passing devices or anything here.
Yeah, it looks like, I mean, I was hating on it earlier, but it looks like you have like a great angle right now. I mean, this is super favorable.
All of the runs repeat. So when I'm scrolling through, it goes through twice.
Okay,
so here's you can see the wasting here from the SMV access site. You can see a small little bump here. I think that's the IVC puncture site. And so we know that our balloon and our stent are going to be, you know, long enough with this measurement using the markers. You know, we didn't pull out a marking pigtail or anything here, but we have the markers from the balloon to get an approximate size of the Viator stent that we need. We put the balloon up. And now the next shot that we have is the 10 French sheath all the way down in the SMV with an injection basically to confirm our position, being in a good spot there. And so at this point, you know, next images you're seeing here is we've sized out our stent. We've, you know, deployed the uncovered portion just as you would a normal tips. Pull it back until you feel a little bit of tension and you're up against the SMV wall, and deploy the tips.
As far as like your landing zone, I mean, obviously like you want to make it into the IVC, but did you have any idea of exactly where you wanted to land it, or weren't too precious about that part?
So that's a really interesting point, because with this case specifically, in retrospect, we focused so much on the window and where we were going to access, where we were going to puncture. We didn't really think too much about where we were going to land the stent. And, you know, an oversight on both of our parts was the fact that we didn't really notice that the patient had a really tight IVC up top. So she had a pretty tight IVC stenosis, and we initially landed the stent. We just wanted to be kind of inside, but then we did a CT run to basically show us the images, and we noticed that the stent was kind of like just barely there. And the thought process was, let's extend this a little bit so that we have easy access in case we ever need to revise this at all. But in doing that, we did it with a covered stent and actually ended up basically occluding the IVC and bringing it up into the area of stenosis. So the mesocaval shunt was flowing beautifully. We had an amazing flow across it. it, but we didn't do a final venogram from the groin. And I actually had to come back later that evening to basically put a second stent in the IVC and open that up alongside the mesocaval shunt. So that was, these cases are hairy. That was an oversight on our part, and we were fortunately able to bail the patient out, but it could have been a really, really bad outcome had we not caught that.
I guess generally speaking, I mean, I don't know, like with the other cases, but, with the size of the Viator stents, what did y'all, I guess I should ask, what did you post-dilate to? Only eight? Okay.
In this case.
Yeah, and so did you know that you were only going to post to 8, or like, are you checking pressures, or?
We didn't check pressures here or anything. We only dilated to 8. Our thought process was leave enough stent in the IVC such that if we need to post-dilate, I mean, hepatic encephalopathy is going to be a similar risk with this case as it is with any other tips. And so I generally try to see how patients are going to do initially. Post-dilate to 8. This was our initial post-mesocaval shunt creation image. And you can see, the injection is going very briskly straight back to the IVC. It's quite a pretty picture. In this case, this is where we decided to extend the stent a little bit. Here we're injecting that distal gastroepiploic vein and then watching that flow basically zip right out. It's very laggy here, but the flow zips right out to the IVC. Here's the lateral shot. Okay, I want to pause this on a good image here. It just wants to move very, very slowly. So we've got groin access that we're injecting from. We've got a catheter from the jugular access into the mesocaval shunt. And when we do a simultaneous injection, we've got great flow out from the mesocaval shunt to the IVC. Now you can see on this image that, this is the shunt diameter here. You can see the IVC looks kind of tight over there. Maybe it looked a little bit bigger on the AP. This was the oversight on our part. But on this picture, it was like, we're kind of just barely in. Should we extend this a little bit further to make sure that we can reaccess this if we need to? And so we did end up extending the stent up there, and that's what caused the issue of the IVC occlusion. So, and I mentioned that complication because, these are rare and sort of complex cases. This is an image post-stent extension. So this is the initial Viator terminating here. This is the final Viator. We extended it. We did an injection, we celebrated and we high-fived, and we're like, oh my God, we created this. Let's see how the patient does. And what kind of happened from here was the patient went back to the PACU and was doing okay. We wanted her admitted to the ICU for overnight monitoring just because this is our first time doing a case like this. And I got a call from the ICU resident, basically panicked because the patient was like horribly acidotic and it didn't make sense. And, the patient's pH was reportedly something like 6.7 or something, but she was awake and she was alert and she was doing fine. And we ended up getting a CTA, which I can pull up here in a second. But the physiology happening was that the covered stent that we extended the mesocaval shunt with essentially had occluded the IVC. And important to ask is, where are you guys drawing the blood from? Because they were drawing the blood from a femoral central line where there was basically stasis and lactic acidosis. And so they were getting a crazy acidemia. But we identified it. And basically, I came back that evening as the call guy and got a wire down from the jugular past the Viabon, wire down up from the groin also. And I ended up putting a venous stent in the IVC while balloon protecting the mesocaval shunt. And basically simultaneous, I got a wire down into the mesocaval shunt, put a balloon up, stented from the groin, and opened up the IVC, and then patient did well.
So patient went to the ICU, discharged home next day, and I'm interested to know what the clinical follow-up was.
She was there for 3-4 days. Because of the IVC occlusion, she did lose a little bit of blood into the abdomen. She had some hemoperitoneum, I think likely from that initial puncture that we did that was unsuccessful. So she required a couple of units of blood, and she required a little bit of pain management after we created this. But I think she was discharged home on maybe day 3 or day 4. Like, it was a pretty quick turnaround. And then she essentially improved with regards to ascites almost immediately, where she was coming in bi-weekly, and we had to catch up on a little bit of fluid that was remaining for the first 2 weeks. But after that, she essentially had complete resolution of her ascites. Omar followed up with her. I'm driving the conversation here a little bit because I had the images up, but you want to talk about that, Omar?
Yeah, her follow-up was really good. She eventually reduced her knees for her paracentesis, and I alluded to this earlier, where she felt well enough to move. Well, the things that were keeping her here were really her knees for the paracentesis, the biweekly paracentesis. She really couldn't travel. She couldn't move anywhere. But yeah, she recovered very well. Once we had sort of taken care of her little IVC occlusion, she didn't need any further revisions. The ultrasound showed patency And the interesting thing about the physiology, really the pathophysiology of these mesocaval shunts and portal hypertension, you get this first splenomegaly, improves, your spleen reduced her size, your platelets kept on improving from less splenic sequestration, her ascites improved. So a lot of parameters, her lab work improved really well. It was kind of a bummer to see her move out of state somewhere else, and we couldn't really have more longitudinal follow-up. But even at the hospital where she was getting her paracentesis from, the ultrasound staff was asking where she was, and we showed the staff these cases. So they were pleased to have seen her at least improving her quality of life.
If you did have your druthers, like how often would you follow these patients up? Like, were you planning to just do standard TIPS follow-up with ultrasound surveillance?
Yeah, I mean, some of these patients, especially the ones that we'll talk about later on, they're either oncology patients of some sort or have pretty routine follow-ups with other physicians. From my standpoint, the follow-up is really just the routine TIPS follow-up and make sure it's open. And the clinical parameters that we're interested in, we'll just see them on the follow-up post their TIPS ultrasounds, which for me, it's 3, 6, 9, 12 months, and then annually afterwards.
You were going to say something, Ars?
It's the standard TIPS follow-ups, but these shunts can be much more difficult to image than intrahepatic shunts with ultrasound, so the clinical factors are really important. And this patient, although we didn't get the longitudinal follow-up that we would like, we did see her about 3 months post-procedure, and she still had complete, a lack of fluid. She had a reduction in her diuretic usage, etc. Her pressures had improved. Obviously, clinically, she felt much better, and she had no signs of hepatic encephalopathy. So with how excellent the flow looked at the end, hopefully this represents some long-term patency. She did end up moving out of state, but only because she felt well enough to do so.
Obviously, you didn't do it, so you didn't think it was necessary, but did the putting a catheter like in the arterial side, like doing an SMA run, any thoughts to that?
We've talked about it before, doing like a portal run, and that's definitely been in our game plan.
One of the patients that we will discuss here, we did end up doing that because she had very complex occlusions and she had recurrently bleeding splenogastric shunts. And the question was, is decompressing with a mesocaval shunt at the level that we're planning actually going to resolve the varices that we're trying to treat? Like, would this patient better benefit from a splenic vein reconstruction, portal vein reconstruction to actually try and get that flow in line? So in that case, we can jump to that one next if you like.
Yeah, those are useful too, because if you can get a good SMA shot and really see the drainage path of the bowel, you might, let's say the planned target might be more of the outflow as opposed to the inflow. You're not really fixing something that's more proximal, because that inflow is still going to run through the varix or that channel. So it's, in my head, it's more ideal to create your shunt before your issue arises anatomically.
Which number patient is this, like in y'all's series?
This is patient number 3, actually. So this was a patient who had basically recurrent GI bleeding. She was a cirrhotic, I think, metabolic associated, or MASH, NFLD, whatever they're calling it these days, with very nice compliant patient, which is another thing that we didn't mention initially, is like, are we going to be able to really have frank discussions with these people? Are they going to follow up properly? Are they going to be compliant with medications, et cetera, if we need them to be? Who had massive splenomegaly and had evolving sort of partially occlusive, then eventually totally occlusive, and then chronically atretic portal vein thrombosis, looking back to scans over the last 3-4 years. And separate discussion for another time on how aggressive to be for portal vein thrombectomies and interventions. But after seeing cases like these, I would much rather treat that patient before it gets to this point than have to do a mesocaval shut. Now, with that sort of statement made, she had a completely occluded main portal vein, which is calcified and stenosed, a completely occluded splenic vein, and then a lot of portal collaterals that were kind of jumping around from this massive splenomegaly over across the stomach, across the duodenum, back into the systemic circulation from the esophagus, but also back to the portal veins through cavernous transformation in the abdomen. And so this was a patient that we addressed in a stepwise problem because she was at a hospital that didn't have the 4D CT scanner. We didn't want to just transfer her right away. She was kind of coming in every 2 to 3 weeks with recurrent GI bleeds. So the way that we approached it was, the initial step was to actually do a partial splenic embolization to transiently, decrease the portal pressures, hopefully improve her thrombocytopenia to make her a candidate for mesocaval shunt creation, and also to do a diagnostic angiogram with a long delay from the SMA and the celiac arteries to see, are the majority of these shunts coming from the splenic vein, or are they coming from the small bowel? And how do you kind of connect the dots between the two and do that? So this was that initial CT scan that's not really running the greatest here. We can send you guys some slides, or maybe put up a little slideshow of all these cases in the show notes at the end if you like also, because that way people can kind of review them at their own amusement. And so let me just jump forward here. Yeah. I mean, considering how much we talk about this sort of stuff, there's got to be other nutheads out there.
We wouldn't have had you on if we didn't think there were other nutheads about it.
Speaking of referral patterns, this was an inpatient consult.
Actually, so this was an interesting one because became an inpatient consult, but she was actually seen by one of our partners outpatient who basically got called about this patient. They said, hey, is there anything you can do? And we looked at how bad that anatomy was. I mean, a traditional splenic vein reconstruction or portal vein reconstruction likely would not be effective here because of the length of disease segment, the complex anatomy of the varices, et cetera. And we had essentially told the patient, well, somebody else had told the patient outpatient that, sorry, there's nothing we can do. Then the patient was admitted at the hospital, and one of the PAs on the GI service asked the same doctor again, just take a look at this again. Is there anything you can do? This lady keeps coming in, she's compliant, she's nice, is there anything you can do? And he basically floated a group text to Omar and I and said, will you guys take a look at this? Is there something you can do? Knowing that we had done a mesocaval shunt previously. And that's when we started working it up and getting involved on the inpatient side. So
just going back to the CT, did you see something that you thought was a potential window? Like, did you see the two sites that you were going to connect at that time, or?
Okay, so in this case, we've got that massive splenomegaly. You can see all these varices over here, and we're looking basically. This is the money shot picture here, where we've got the largest SMV collateral, okay, and then a straight window with nothing in between to the IVC. And the thought process here was, okay, the gallbladder's here. This is kind of the inferior aspect of the falciform, but theoretically, either under CT or potentially even under ultrasound, we should be able to find this SMV and then puncture straight through into the IVC and then connect the dots from there.
This actually looks like, from a pre-procedure standpoint, pretty favorable. I mean, having done zero, but that did seem like opportunistic, that there was a huge collateral.
We are showing it, so it would be successful.
So that was the fun part about this case, and not to get ahead of ourselves, but Omar, like a beast, basically found that under ultrasound, punctured from the SMV to the IVC under ultrasound, and we were in and out of there in like 70 minutes. Like we walked out of there basically being like, okay, that was kind of too easy.
That's gotta feel good.
We didn't need two people.
So how tight was the window? Like whenever you were looking under ultrasound, like could you see it like threading?
We have a really good picture of it. So this is her celiac run here. And on the delayed, you can see these gastric varices filling here, okay? And we also, this is my partial splenic embolization, or proximal splenic embolization. I apologize, I misspoke earlier. Then we did a mesenteric run, deployed a single plug. This is a celiac run post showing slowed flow. So here's our initial 4D CT scout image. We've put a grid on thinking that we're gonna access percutaneously through. And then under ultrasound, we've got this beautiful picture here. So this is basically looking, axial transabdominal image. Here's the SMV right here. These images you'll have to zoom in. I apologize because this is hard-coded in there. It won't remove, okay? So this is the initial transabdominal image. You can see the gallbladder right here. This is that falciform sort of window. This is the stomach gassing out over there. There's a little bit of ascites here. You can see the liver margin. And then we basically saw, put color Doppler on, make sure this is venous, it's not pulsating, it is the appropriate size. It looks like our initial CT image. And we've got the SMV right here and the IVC right back here. And so here's the image basically of the wire basically going straight through the SMV into the IVC. And after that, we did a CT image showing that we weren't going through anything critical. Our wire was exactly where we wanted to go. That's the initial scout. So here's our Hawkins needle. Come in right alongside the gallbladder, alongside the liver, into the SMV right here, okay? And then from there into the IVC, and there's the tip of the needle there. So from there we just pass
just
it.
above the stomach.
Yes.
It's not going through.
It's not going through the stomach. It goes above. Yep. We did have coronals and sagittals. We're reformatting images to make sure we're in the right place. And then obviously when you're puncturing into the veins, you always want to make sure you have blood return also. So once we've got our wire through, basically this is the angle that he took. You can imagine that's a similar angle. Snare from the neck. This is part of the Chengazi magic. I think they saved some loops that make us look not that good.
$1 a week.
There we go.
There you go.
There you go. Third try. Third try. And don't mind the hands in the image when you're working under the adrenaline in a case like this. You don't care about the collimation so much. Pax is deciding to cooperate here a little bit more.
All right, so now you're flossing, you're pulling that through. And again, this is another, so the needle used to access another 18 gauge, and then you're threading the 035 glide wire exchange length.
The exchange length soft glide wire.
The crawl recon, yeah.
Yeah, I'm just scrolling through all the images because...
We also did a BRTO wire just to sort of further reduce bleeding while she was waiting for the lab time to do this.
Yeah, a lot of coordination went into getting the anesthesia set up, the 4D room set up, etc. So in that time, we started with the splenic embolization, did a BRTO to temporize those other varices on a separate intervention, then came to here. Now, we accessed, Omar, this case, it wasn't the Hawkins. I think in this case, he used the AccuStick, right?
Yeah,
we initially accessed with Hawkins, and then we switched over to the AccuStick sheath, basically to allow us to get 2 018s in. It's, it's a 4 French sheath, and you can squeeze them through to get a buddy wire system through.
That's just the wire.
Yeah, so this is the wire going up into the IVC.
All right. Yep. Yeah.
You can see from the skin, kind of going over the top of the stomach. You could tell we're not going through the wall there. You're like, okay, patient's doing great. Sagittal is the same thing here. It's the sagittal. So the way the images came across.
I see.
There's the sagittal coming. There's the SMV. There's the IVC.
And so then, after you have wire access, it's rinse and repeat.
It's a big tips.
Pre-dilate with the 8-8 and then 10 French sheath down.
You can see here, it is rinse and repeat, but we did leave a buddy wire in. So we essentially got a sheath into the IVC, buddy wired, and then pulled out and then worked over the other wire, because in the second case that we did, it struggled a bit more getting the sheath down over and had to re-snare a couple of times basically to get that access across. And so having that buddy wire allowed us to not have to repuncture or risk losing that access the whole time. So then we, balloon up, sheath down into the SMV. These are out of order. I don't know why they're coming across like that. This is our sheath shot, basically showing the SMV and the cavernous transformation into the liver. Uncover the uncovered portion of the sheath and retract into the IVC. In this case, we went with a slightly longer stent off the rip to avoid the need to extend or anything. The patient also didn't have an IVC stenosis or anything. And this is an injection basically through our access sheath to show that we're good. Now we've aborted our percutaneous access, driven a catheter from the jugular down into the tips or the mesocaval shunt, and we're injecting and showing excellent brisk flow out into the IVC. And that's the final image of the case there. So it's interesting because obviously we didn't do a whole lot of work trying to go up into those splenic varices or show that around. Part of the thought process there is essentially just flow dynamics, right? If you create a low pressure outflow, even the varices that, all that whole network is connected, it'll want to reverse flow or preferentially flow out the easiest path. That's also what reduces your risk of bleeding. And she hasn't bled again since this procedure. We're well over 6 months out at this point, I think. Well, no, sorry, I misspoke. We're at about 4 months out.
All right, very nice. Do you have the case where the one that I think a lot of people saw on Twitter, where it was like the long access under CT guidance?
Yeah, that's the one where we got very creative.
These are all good cases, frankly. Like each one of these stands on their own is like a super...
But even with this last case, just like the other ones, her Ascites is gone. When Horace mentioned earlier about the change in the flow dynamics, she was one of the patients where you could see she was holding on to a lot more intravascular volume. She had no more ascites. Her veins are actually more engorged. She'd have less bleeding, but she also developed some effusions. She used to develop more lower extremity edema, so you had to modify her spironolactone, her diuretics. And because now she has more venous hypertension from the off balance with the portal hypertension, she's developed varicose veins and worsening venous insufficiency. And RS is going to be treating her for that down the road.
Yep. So she had bilateral venous insufficiency beforehand. It clinically just worsened, I think, with the higher the venous pressure from the increased return. So she had like 5 seconds of reflux in her GSV. I'm bringing her in for variceal, but I spoke to her cardiologist. I spoke to her GI. We doubled her spironolactone dose. She no longer has, any ascites. Her leg symptoms are improving. We've got her in compression. Complex IR clinic, we're managing more than just the procedure, and there's a lot of other work that goes into it. But the biggest thing that, this patient, openly tells us how much better she just feels. I don't know if that's just because she's not bleeding. I don't know if that's because she's, her heart is got more blood return to basically play with and sort of go from there. But she feels better. Her color's better. She's got more energy. She's gardening again. I mean, she's got her life back, which is great for a person who's, later in life and just wants to enjoy her time.
Well done.
So this is case number 2. Omar, why don't you tell this? He had a very interesting history as well, because I think this is a person that a lot of people would just say, sorry, man, there's nothing we can do.
He was an outpatient consult, and I want to say he was 4 at TIPS, and I can't recall. He required almost weekly transfusions for just occult blood loss. Platelets were low. He could not. I think he had pancreatic cancer too. So he couldn't continue his chemotherapy. His oncologist said, we can't do anything anymore. Your platelets are way too low, and your blood count is just too low. You're not going to be able to tolerate it. And they came in for a TIPS consult, and I told them, the TIPS is not a possibility here, but we could potentially do this mesocaval shunt. And his major issue was portal vein occlusion, cavernous transformation, and he had profound duodenal varices that were his source of occult bleeding. They've been banded before multiple times, but they keep coming back just because of his main outflow of his portal system.
And why is his portal system down again? Is it because malignant?
So he had locally invasive pancreatic cancer. And so he had pancreatic cancer invasion into the upper SMV. And part of the reason why the TIPS wasn't the option for him was the main portal vein was also out. But in that case, because of the SMV occlusion, he had all these paraduodenal varices. They're very, very
extensive. So he was more pre-sinusoidal from SMV occlusion.
And so by decompressing with just a traditional TIPS, you wouldn't decompress those varices because they would still want to flow through the duodenum. I mean, you may reduce the pressure and so make them less likely to bleed, which is, a thought process, it's something you could consider there, but you wouldn't be directly intervening on those varices. And so our thought process is if you could bypass them altogether by going into the SMV from below those and then going to the IVC, then you're going to remove that nidus for bleeding.
Yeah, there's all the limitation too, is you could argue why not do a traditional TIPS and extend down to the SMV. It's there's no way to get the main portal vein down into the SMV. It was just, there is no even chronic channel to try to get across into. And in my experience, I don't know about yours, Chris, SMV stents don't do very well in TIPS. And anytime I try to plastine stent, they've just shut down.
Okay.
Another thought, Chris, just on a side, is that it might just be worthwhile to just link the Twitter post, because that's got all the key images, and it's also got the follow-up images of the collapse of the duodenal varices. So, all right. So here we have his initial CT. We'll show some images from the contrast enhanced prior, but basically he has this SMV branch here and the IVC right over. So the window itself is very short, but the question is, how do you get there? And initially, when we looked at his contrast enhanced CT, we're like, oh, okay, there's a window over the stomach and kind of, around the bowel, and we can get there. But when you're actually on the table, it was kind of a different picture because there was a lot of small bowel overlying. There was a lot of mesentery overlying, and the stomach was pretty distended also. So what we ended up doing was essentially using a trick, I learned for difficult biopsies in residency, was to essentially get into the peritoneum with a sharp stylet, switch over to a blunt stylet, and then we basically just intermittently sort of angled the needle heavily and advanced, go by feel basically, to get to where we needed to go. So I'm going to jump forward so here's our initial puncture into the peritoneum. We're kind of close to the stomach there, but we were able to angle away. We switched to a blunt stylet at this point, and intermittently did use a little bit of air and fluid to hydrodissect, to pneumodissect structures away, and then put the blunt stylet back in and kind of reposition. So, I'll just go through these slowly. We've advanced. The target here is the SMV there, and then we've got a wire in the IVC already, so we're ready to snare when we get there. So now needles past the stomach into the mesentery. We've got mostly fat along the way. There's some small bowel that kind of comes in. Switch over. Once we got up against the wall of the SMV, we switched over to the sharp stylet. This is the picture of, I think, this is the needle where we actually punctured in. Yep. And so at this point, we take the stylet out, make sure that we've got blood return. Then we angled a little bit medial and towards the IVC and popped through and through. So there's the next picture there of the IVC basically being punctured through the SMV here, IVC here. We're through and through, pulled back a little bit, advanced a wire. And, we floss the access, and here's the image that we have after the floss access, where you see the wire coming down the IVC over here. You'll see a whole bunch of contrast there also, which we injected along. When did we do that, Omar? Basically to prove that we weren't in bowel.
Yeah, we want to make sure we're in luminal.
Yep. So we did inject a bunch of contrast through the Hawkins needle just to see if any bowel opacified along the way. And that's where we kind of saw that the stomach had kind of...
Did I miss that? Like on the here's when you were creeping up?
Man, when was this case? Because we didn't do it intermittently along as we were going. We used some fluid and we used some air. How did we do the contrast injection? I can't remember exactly.
We did a pullback contrast run injection from our access.
And again, this case, it was a same AccuStick sheath now that I'm remembering. We got in, we flossed with an 018 wire, and then we injected from the 4 French sheath as we retracted to make sure that we weren't transluminal.
Yeah, with little two.
Okay. I see.
Okay, so that's that image there with the contrast in place. And I'll switch over to our angiopics because that's about as much as we used our CT scanner.
All right, so at this point, you're flossed out the neck from the transabdominal puncture. Heroic puncture, by the way.
Very fun, man. These cases they're stressful, but they're very rewarding as well.
I mean, look, I'm feeling the reward on the other end of it, but like as I'm watching like the needle trajectory, I'm slightly puckered up because like it's tough.
I think there's another point to be made there these cases aren't for the faint of heart. Like you have to... I think the biggest point is, I always learn that you could teach any monkey to push a needle or to do a case or whatever. And what I think may not come across in these discussions and like, oh yeah, this is what we did and we were successful and we were out, is the hours of back and forth of the planning of the what if this happens, what if that happens, what if we do this, like there's so much discussion and so much planning and so much thought that goes into these cases before you take on something like that, because the fact of the matter is that we're doing stuff that is not people get denied for procedures that are quote unquote experimental, but we're doing them day in and day out and we know they work. This is truly experimental, where like, yes, there are a couple of case series of successful mesocaval shunts. I think there's, maybe 3 or 10, there's less than 10 cases published out there of doing it this route. And so we are really sort of on that cutting edge and on that sort of frontier of interventional radiology that is super, super exciting, but also very dangerous, because you don't want to harm people. And fortunately, I think we're very lucky, and I have to attribute at least a portion of it to luck, in that all of our patients have done well. We haven't had a bad outcome. Everybody has done clinically well, et cetera. But I must acknowledge the fact that any of these cases could have gone horribly the other direction. That needle could have gone through the stomach and we could have created a gastric perforation. That IVC stenosis and occlusion that we caused could have caused a patient to exsanguinate. Again, not for the faint of heart. Putting this podcast out there isn't to say, hey, everybody should be out there doing these things. But if it does at least spark some curiosity into what is possible, of course, we have equipment available to us that isn't available everywhere either. But what is possible, and then, hopefully help other people want to collaborate and think of ways that we can find new ways to do things, because I think that's one of the best parts about interventional radiology and something that makes me love what I do.
Well said.
For sure.
Well said. All right.
Going back to this case. So floss access. Omar has some ORIF hardware in his hand. So I know that was him. I'm working from the neck there. This is another case where we got that 4 French sheath in and got 2 018 wires in and then switched over to work over one access to make sure, because in this case, it was actually very, very difficult to get any sort of access from the jugular into the SMV. We were having trouble coursing, 65 burn catheters, even a 4 French glide catheter. We kept butting up against the SMV. And I think, that's probably because part of the occlusion in this case was due to tumor infiltration. So we were just dealing with much tougher walls than you were in otherwise normal veins. And so we actually lost our floss access once or twice. I think you'll probably see images of us snaring again. But here we have we're injecting through our access needle. Once we've got our wire through into the IVC, I should go back there a little bit. We punctured through and through. We passed a wire. We got that access. Then we had to basically pull that access back into the SMV to make sure that we were inside the SMV so that we could get a good picture, essentially. Because we didn't take a picture when we got the initial blood return from the SMV. We were committed at that point to going into the IVC, so we didn't know what that anatomy looked like fluoroscopically. So after we got that floss access with the 018, we've pulled it back. We've done this SMV run. And then from there, our goal is essentially to work from the jugular and get our access down to the SMV again. So
is part of the problem here also the angle? I mean, this one just looks a little bit steeper, like you're coming into the IVC at a bit of a 90-degree angle.
Yeah, we're coming into the SMV at the 90-degree angle, I think, is the toughest part, because then, that's a much smaller space. The IVC is not as big an issue because once, you pull, it kind of straightens out. But in that SMV, you've got a really small landing zone, and it's really easy to push your needle out and lose that access. So here we're flossing for a second time after losing access, but we had that buddy wire in.
It's not losing access if you have the buddy wire.
Fair enough. After we're just getting frustrated because it's like, okay, we got to get this done. I think what had happened when we tried to come down from the jugular, we were pushing that access needle back. And because you had such a short sort of landing zone, like you've got stiff access here, you're coming from the jugular down, we kind of pushed back. Like you could go through or not far enough. And there was a very small window where we basically had to commit to losing our access, our floss access, so that we could work from the jugular access to get into the SMV. So if you were too far and your wire was beyond, then if you pull back, now that I'm recalling, because this is months ago at this point, recalling that's what we were struggling with, was making sure that we had our catheter in a perfect position so that we could advance a wire from the neck into the SMV. The sheath that we had in the SMV didn't give us a lot of room either. So this is one of those shots where we thought we were in, and we're obviously in the peritoneum there, and so we've got to reposition and basically revisit that again. Buddy wire's in there the whole time. So here's snaring for the third time, getting our access, and now we were successful in getting our catheter all the way down to the SMV. You can see, we'll correlate this to the CT images as well, but these are all paraduodenal varices that were bleeding here, and then going up to the liver there. And you can get a sense on these images also why the TIPS access would not have been an option. I mean, what do you access here? Where do you deploy a stent? These are all tiny little veins. So now we've got our sheath down, okay, injecting again and seeing those varices filling pretty extensively and up to the liver. Deploy the uncovered portion of the tip stent and then retract to uncover the rest of it. You can see the wasting for the extrahepatic portion of the shunt. So there's a very small window, but basically the SMV wall is here, the IVC wall is there, and we plastied that open to an 8. There's the balloon, and I think this was a case where Omar and I were debating how much does the sheath being through your tips actually affect your venogram. And I told him, don't do it, man. It's not going to make as pretty of a picture. So we have the sheath all the way down. He injected and we're still seeing the varices. And I'm like, why don't you do that same injection?
Hard.
Yeah. The guy works out. I don't know if you've seen him. He injects and I'm like, okay, we're going to repeat that with a smaller profile. And so we do the final picture here through a catheter into the SMV and the flow is all obviously preferentially up to the IVC. Yep.
Okay.
And there you have it. And we'll share those images of the duodenal varices in this case collapse completely. Omar, you can talk about how his clinical course.
He did very well post procedure. His duodenal varices pretty much collapsed. They're still there, but the hypertension component is gone. His bleeding is resolved.
He's been able to tolerate chemotherapy, which is the biggest thing. Is the guys.
Yeah, and in all these cases, they've all presented with some degree of splenomegaly. Once this has been created, their spleen has reduced in size by at least 2 to 3 centimeters. And I imagine it would continue on. And his platelets are improved. He's back on chemotherapy, and he couldn't be happier. The daughter's very happy to know that he still has a fighting chance for a few more months to who knows how long.
Yeah, we're over 9 months out from that case, and the patient's still alive with pancreatic cancer. So it's a win in that regard.
So let me throw some questions at you guys. Key to the case, if I had to guess, pre-procedure planning and knowing your SMV access and your IVC access. Like finding that window is like crucial in all these cases, right?
100%.
How important is the 4D CT scanner? Do you think, one of the cases you didn't need it, but
I think it's a great utility to have to prove your access is safe. I think having it around in scenarios where you got, dodgy access, are you through bowel, are you through any veins, you need to make sure. You do need it in some regard. You definitely don't want to go through bowel and then deploy tip stent because then you got a dirty implant.
Yeah, I think 2 of these 3 cases, theoretically, we did without even needing.
Yeah, that's what I was thinking. Like the one case, like the last case you showed was mission critical, but the other cases, it was definitely an adjunct, and I think it made you feel better about it, but...
Mm-hmm. Yeah, absolutely. So in the right scenario, could you do these cases without? Yes, absolutely. But I think when you're charting sort of new territory, it's not a risk that we would have been comfortable taking. Now, depending on the right anatomy, etc. That first case, did we really need ice? No, it didn't really help us all that much. And we ended up puncturing under fluoro, which is pretty similar to a bunch of sharp venous recanalizations or gun site tips or whatever else you may be doing. So the skill set is there. I think it's just, you just have to think outside the box and really consider and look at the anatomy beyond just, do I have a patent vein? Do I have a good target? And that's it. Because it's not a TIPS, you're not going through liver. You could be going through the pancreas. You could be going through the duodenum. You could be going through a different vessel or a different collateral that you could occlude, or an artery, or whatever it may be. And so the 4D CT really just helps us prove that we were in the right to safely deploy a stent, whereas, that's not as much of a consideration with other accesses.
So in going from case 1 to case 4, what are some things that you've learned along the way, or like what are some tips, like if you could give it to the audience, that either some struggles that you had early on that you're not having later on, or some considerations that maybe somebody who's thinking about trying to take this case on, you can give it a couple pearls.
I'm going to say collaborate with somebody else in your group. It definitely takes two minds to sort of come up with a game plan. That anytime I've come across this problem or these patients more specifically, I'll shoot hard as a text and, hey, take a look at this scan. What do you think about this potential window? We're always kind of shooting out ideas. So if you think you see a window that where you can connect an SMV collateral or main tributary or main branch into the IVC, and you have, a clean window percutaneously, you can think about it, run it by your colleague. But you also need to have a proper shopping list. We have one potential case coming up later this month, which would be, one thing we didn't really talk about was your access point within the IVC. How far down the IVC are you going? Are you going intrahepatic? Are you going subhepatic? Are you going infrarenal? We have one case where we will be going infrarenal, but then that lends you, okay, what size sheath do we need? Is a 45 centimeter sheath going to be long enough? Right? Because we got to then deliver a tip stent. If we can't deliver a tip stent, what's our backup plan? Do we do a fluid seawall stent combo? Stuff like that. So having your backup shopping list, are you going to have any arterial extravasation? What's your backup for doing an emergent embo? So you do need to have all that stuff ready, because especially where we are, like Har said earlier, we're outside of our traditional lab. We're somewhere else in the hospital where we don't have our equipment.
Okay. Hars, anything to add?
Yeah. My other pearls would really be about the, it's on the more practical side. Like, anybody looking at these cases can think, okay, the anatomy is good, but then there's a lot of other logistics, et cetera, that don't even come across in this discussion, because the third case that we did, where we ended up doing the ultrasound guided access, that case realistically took us less than an hour. But we basically, it had been time since the other cases. We set anesthesia up on one side because that's how we had did a different patient. But because we were accessing from the right on that side instead of on the left, all of their devices were kind of in our way, and we had to completely reroute all the ET tubing and all this stuff. Like, are we going through the CT scanner or around the CT scanner? Because it's not just the table moving, there's that whole ring coming in. And so there's a lot of those logistics and stuff that you kind of forget about, because our technologists are very good and they set up our patients for our routine cases so quickly. But now when you're doing something that nobody's ever done before, they don't know what you need. They don't know what you might need. They don't know where things are supposed to go or where they might be in your way. There's a lot of planning that goes into that aspect of it too. Omar raised a really good point about having that second set of hands. I mean, I've done complex cases where I'm running from the neck to the groin. This is not a case that you want to be doing that. And the bouncing ideas off is both before the case and during the case, because it's like, well, what if we're spitballing, like, what if we did this? What if we did that? Hey, this isn't working. Why don't you do this? I'm going to do this. Why don't you do that? There's just a constant communication, which I think is imperative to operating at a high level as well.
Well said. Yeah, sometimes like big cases like this, when you're trying to go back and forth between two different locations, like from neck to groin, or in this case, abdomen to neck, there's just like case fatigue that kind of sets in. Like, like if you're trying to re-snare that wire, like for the third time, I know like I've experienced that before, where it's just like, just the whole like activity of the case becomes like a real bear and kind of becomes defeating. Okay. When you were first prepping for the very first case, what were you reading? Like, do you think you guys could link to any articles, or I would imagine you read the case series that exist out there on mesocaval shunts and for procedure prep?
Yeah, we can share that article. There's one case series that I remember is a case series of 3, where they had slightly different techniques for the different patients. And I think, Omar, it's time that we maybe updated the literature and published all these cases and talked about it to put it out there.
I found something on seminars. I can link to it also. I think it was I think it was relatively recent, within the last couple of years, a seminars of IR case. And they were basically using gun sight technique, but all the same stuff. All right, final thoughts.
We're planning one more. That's going to be, you know, Omar mentioned the low access. I mean, just to mention that, because it's another case similar to the one that we did with the duodenal collaterals, where this is somebody who had remote surgery that required an SMV ligation, did well for a long time, but now is basically bleeding, you know, recurrently from all these duodenal and jejunal varices. I mean, they're massive and they're very impressive. It's a situation in which the portal vein is wide open, the intrahepatic portal veins are wide open, the SMV is wide open, but the lower, you know, the upper portion of the SMV is occluded and the lower portions are completely, you know, draining via those collaterals. And in that situation, the patient doesn't have a history of cirrhosis. His portosystemic gradient is not elevated. So creating a TIPS would not improve the bleeding. And so it's probably going to be the toughest one that we did yet. But there's a lot of discussion that went into it, because it's like we've got to access below the level of the varices to bypass them, hopefully get the patient. But it's also riskier in that regard, because if we don't properly deploy our stent and we cover jejunal branches or something like that, then I think this patient's also at higher risk of bowel ischemia. And so that's, you know, just another one of the things of like, you got to think of everything that could go right and everything that you could do, but also everything that could go wrong, because, you know, I truly am a believer in properly informed consent. And when you don't have literature or numbers or percentages to back things up, patients really need to understand everything that could go wrong.
Yeah, the informed consent you guys are filling out must be like 3 pages long.
Do it in a consult beforehand. So the informed consent just says discussed.
Okay. Omar, anything to add? Final thoughts?
I mean, this all stemmed from wanting to give patients some better quality of life. You know, this was never about, we want to do cool stuff. Like, it was never about an ego-driven practice. This really is just having compassion and empathy and caring for these patients that otherwise have no opportunity to spend time with their family and enjoy what they have left on this earth. And so our successes have been great, but it's never been driven by, or we want to do something complex, let's go find it.
All right. Well, I got a feeling that after you guys do this podcast, more might be in your future. It might become a referral center for this kind of stuff. Guys, that wraps things up. We'll see you next time on the BackTable podcast. One more thing before I forget. If you guys get BackTable emails, they come from chrisbeck2@backtable.com. I get everybody's out of office emails, and like there have been a ton this summer. One of the fun things to do, it's not like I pretend to read like all the out of office emails, but we have people from Japan that follow. I received one from Dr. Ralph. That one was in German, and so I just thought that was a pretty cool thing. But more importantly, if you ever guys want to get in touch with someone from the BackTable team, all you have to do is reply to the newsletter. I get all these emails, so just know that. We'll see you next time on the BackTable podcast.
Thank you so much for having us, Chris.
Thank you, Chris. Appreciate it.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.